Okay, second introduction, and he does merit a second introduction because he's special. Chris Gostout has come 3 out of the 6 Long Island Lives. He's become basically the father of the course and keeps things in track. And as I said, he's the inventor of it all. His submucosal tunnel technique is what spawned POEM. Now it's submucosal tunnel resection. I'm sure it's going to revolutionize ESD and make it easier for all of you, an important point. And I'll let him describe all these novel techniques now.
Okay, good morning, everybody. It's always a pleasure to come to this course. And as everybody has said, this is the one live case course that you will really see the frontiers of endoscopy. There are lots of live case courses that I participate in and have witnessed, but if you really want to see where the future of endoscopy is going, this is the course that does it. So I'm really, really happy to be here and to participate in this event. I'm very happy to give this memorial lecture again this morning. Stavros gave me a very loaded title to my talk, and I will actually work through all the subtleties that title presents itself. So put your seatbelts on and let's get started. These are my disclosures. They're also in your handout. Let's begin with just the concept of flexible endoscopy beyond the lumen. And I'm going to look at this or examine it kind of chronologically. So if we start with the basics, and that's perforation. That's endoscopy beyond the lumen. That's an unplanned adventure. And I would expect most of you have been there at some point in time. We actually learn from those things. And now that we go beyond the lumen, when we perforate, we learn even more because we kind of stop and look around. We started transgressing the lumen intentionally in the 1980s with pancreatic fluid collections, and we really hit the mark insofar as pushing through the GI wall with the concept of notes that was proposed originally in 1998, and then after the NOSCAR group formed in 2005 from SAGES and ASGE, and really propelled the notion of flexible endoscopy beyond the lumen. Our concept of tunneling began in 2004. We excited ourselves when we realized we could safely turn the submucosa into a working space and exit into body cavities, especially the chest, safely and without remorse. The transluminal approach finally exited the GI tract with the concept of the patent percutaneous assisted transprosthetic endoscopic therapy. And this is an example, an illustration of a common application of this technique. So we're no longer even in the lumen. We're going through percutaneous tracts, dilating them up after the interventional radiologists have gotten to the site. This is a common site that we spend some time in the perinephric space as a result of complications of necrotizing pancreatitis. Can put in a stent to maintain the tract open, and then convert what would be months of drainage and flushings a couple times a day to a more aggressive debridement procedure that can turn the patient around a lot faster, called patent. And finally, today we're doing all of the above, including full-thickness resection, as Stavros had mentioned. This is when we opened up the developmental endoscopy unit in 1998, this was the concept drawing that I gave to all my fellows, and I said, this is ultimately where we want to be at. As you notice, the endoscopist is standing somewhat similar to the laparoscopic surgeon. Both hands are free, working on or through the endoscope, doing transluminal procedures. We haven't totally arrived at that point, but boy, we are really close. Okay, so first of all, we're going beyond the lumen. So the big issue going beyond the lumen is closure. And so how does the transluminal access, how does it influence our decisions in making an unequivocal, confident closure? Because that's the key point. That's the point that makes the surgeons nervous and start drawing cards as to who's going to be on call later that night. It's closure. It's all about closure. And in the endoscopic intraluminal world, the closure, the openings we make, or the access, there are two modus of operandi. The viscerotomy, which we talked about, going through the gastric wall, for example, in situations of pancreatic necrosis, And then there's the tunneling method, which I think is the new paradigm in approaching safe, sound, sterile cavities. But each influences how we make the closure. So a viscerotomy, less than 2 centimeters, actually one of the best closures is the Omental plug. So let's first, here's our viscerotomy. This is your standard off-the-shelf gastrotomy. After the initial puncture is made, most folks are using a balloon gastrotomy because it reduces the risk of bleeding. This will create, if you use a 20 millimeter balloon, a 2 centimeter defect that you ultimately have to close. In this particular case, you can see a bulge, and this happens to be a gastrotomy for the purpose of dealing with pancreatic necrosis and sepsis. But as I mentioned, probably in a less than 2 centimeter hole or opening intentionally done, probably the best closure really is the Omental plug. It's natural. It works extraordinarily well. It's got a history behind it, and I think it actually works better than any of the cool devices that we have. This is an example of an Omental plug. This happens to be in a pig model. We did a study looking at the use of Omental plugs to treat acutely perforated peptic ulcers, which we do as part of our practice now. And in this particular video, as you're watching, we had gone through a perforation in the stomach of a pig, and part of the procedure is to lavage the peritoneal cavity, look around, and find out if whether or not pursuing an endoscopic procedure is good at that point. But this is the part I want you to focus on. This is the Omentum that's literally being pulled through. This is about a 15 millimeter full thickness hole that's been festering in an animal for about a half a day. And notice how it's being tugged. Just that Omentum is a fantastic opportunity to confidently close a hole in the GI tract, especially in the foregut. The alternative choice is the over-the-scope clip. This is this is well liked by a lot of endoscopists because it's a cap-based procedure similar to endoscopic banding. The caveat here is it has size limitations, and you really shouldn't be thinking about this for any full-thickness defect or viscerotomy that's approaching more than 2 centimeters in size, because it's cap-based, and it's going to give you dog ears. You'll get into trouble. If you have a viscerotomy that's greater than 2 centimeters in size, nowadays the only real answer to deal with that is by suturing. When we shift into submucosal endoscopy, I'm going to run this video, and you can watch a submucosal procedure in the stomach. Our choices, again, can be varied. In the esophagus, clips work very, very nicely because, in effect, as you watch this video, we're going to create a tunnel, in this particular case, that's about 10 centimeters long. And as you watch this tunnel eventually crossing the greater curvature of the stomach, that overlying mucosa is a perfect Band-Aid. So we've actually studied this in the lab. You really don't even need to close the opening of this tunnel in locations like the esophagus and even the colon. Stomach's a different story because as you look here, the mucosa is thick. It starts to get hemorrhagic as we manipulate it, and it can be very, very difficult to close that opening. So in the stomach, an over-the-scope clip could be a good choice. Here's the tunnel, as you see, going across the stomach. And if the clip, after this becomes a large rent, then suturing is the most confident closure. Now you're going to get a view with the endoscope going into the tunnel itself. So this is a bluntly dissected space, so we don't have to worry about coagulated tissues. And that will enable the roof or the overlying mucosa to effectively seal that tunnel and be our safety flap valve, as we call it. And this is just a wire going to the peritoneal cavity, a balloon viscerotomy through the residual muscle layer that brings us into the peritoneal cavity. In the rectum and the colon, the story's a little different. This is a tunnel down in the rectosigmoid. That's the exit point into the peritoneal cavity. Here we do have the peritoneal cavity that's wide open, and that's the entry point in the mucosa, and that lends itself very nicely to a confident closure with just using clips. So depending upon the style of access, whether it's tunneling or a direct viscerotomy, size can influence how we close confidently, and the location can otherwise influence what choices we make in closure. So more on closure. How strong should a closure be, or how strong are these closures? and for what types of closures. So in theory, the flexible endoscopist is making a single layer closure, taking all the layers of the gut wall and opposing them together. That's the basis of this style of closure, regardless of the tool that's attempted to be used. The goal also behind all this is to get a serosa to serosa apposition, because the serosa fuses very, very quickly and becomes a very effective seal against contamination. Surgeons have options. If they're hand sewing, they'll often talk about a two-layer closure, seromuscular closure and then a mucosal closure. We can't do that. We have to do full thickness. And these technologies approach full thickness, with the last probably approaching it in the most durable fashion. So what do we know about how strong they are? This is a benchtop bursting pressure example of how we measure the strength of these closures. This is a pig stomach, and as you can see, there's a bunch of gizmos hooked up. We pump gas into it. We make a closure. If we make a closure with clips, the bursting pressure of that closure site is about 40 millimeters of mercury. We don't know much about tissue anchors in their bursting pressure. They come in all shapes, varieties, and forms. This is a collapsing basket-type tissue anchor. That's we call a star anchor. That's another collapsing basket-type tissue anchor. And this is a simple T-tag. The bottom line with tissue anchors and closure is they can be very, very effective. The problem, as you see here, it's a blind puncture with a needle. So you don't necessarily know where that anchor is being deposited. Is it in the left lobe of the liver? Is it in a chunk of small bowel? And that's the reason why we don't see tissue anchors right now as one of our options for closure choices. The over-the-scope clip closes with a burst pressure a little bit, actually just a tad more than clips. And then finally, a suture closure is the most robust at 79 millimeters of mercury. So now I'm going to shift into suturing itself. Suturing is long awaited, and it's often mimicked, as I just showed you. If we ask all of you out sitting here this morning, what would be your wish list? Invariably, a top request has consistently been, give us a mechanism to suture, just like the surgeons do. So it's a very desirable function. It was first reported as a potential option by Paul Swain in 1986 at DDW, where he described a sewing machine. That evolved into the Endocinch device. It was a bulky, cumbersome device, but it actually initiated suturing within the gut lumen. So it's not around now, but it really opened up the door. When the Apollo group got together in 1998, Sidney Chung from Hong Kong said that we needed to have a suturing device that mimicked the curved needle that the surgeon uses, and it would enable us to place stitches on demand wherever we wanted. And that gave birth to the eagle claw that you see photographs of some of the earlier versions that we worked with. And this did indeed capture the essence of the curved needle. It was unique in the sense that the suture was attached to the needle point, which was transferred back and forth as the suturing process continued. The Apollo group then advanced the concept further and developed the overstitch device. This is the first clinical version that was available. Again, you can see the concept of the curved needle was maintained, the transfer of the needle tip with suture, a very simple, basic suturing mechanism that would allow one to duplicate a hand-sewn suture line. As you can see here, this handle is pretty big, complex. It's larger than the scope. Things always get better. So just keep that in mind and then watch this version. This is the latest version of the flexible endoscopic suturing device. There's only one type of endoscopic suturing device in the world, so I don't have any problem showing this with the logo on there because there really are no other choices. But what I want you to focus on is a simple action. So think of yourself doing a closure. Here's a 2-centimeter closure. This happens to be in a pig stomach because it was created for the purpose of this kind of a venue where we can describe suturing and how it's done. So this is how the tool works, and this is how you see it being done. So stitches are placed using the curved function of the needle. In this particular example, we're using a grasping forceps, but we also have a screw-type helix device that will grasp the wall of the gut full thickness and bring it up into the jaws of the suturing device. So what I want you to focus again on is not only just the sutures being placed, it can look kind of confusing, but there's a transfer going on right here where the needle tip with the suture is grasped, taken off of that curved arm as it's retracted and gotten ready for the next stitch to be placed. The other observation I want you to make is the endoscopic view that you see here. It's really not impaired. The endoscopist can see very nicely what's being done. You'll see it today in live cases. And you'll also notice that this is a tedious process. This is not something you're going to zip through. It does take time to close. And it also takes time to close if you're sewing by hand as well. So haste makes waste. In this case, the mechanisms will prevent you from rushing too far. But as you can see, it's a slow, steady process, but it's a very effective process. This particular closure will use 2 sutures. The first suture it'll be a running stitch for about 6 to 8 stitches, and then there'll be a little dog ear at the bottom that you'll see in a few seconds, and that will be closed separately with a second suture line. Now the difference between what you're seeing here and what would be done by hand, a hand closure could be interrupted, 2 stitches and a tie, or a running stitch, and you'll get a linear closure pattern here. Because this is a cinched closure, which you will see, the suture is dropped upstream and the tail end of the suture is downstream. And then these are literally pulled together, and as a result that compresses the tissue. And so rather than a clean suture line, you'll see more of a compressed suture line. Very effective, as you can see from the bursting pressures that I showed you in the slide before. It's tremendously sound, and it should allow a confident closure. Here we're getting towards the end of that suture line. We call this a dog ear down at the bottom, where there's always a little space or an opening that you have to watch for to make sure that gets closed. Again, the repetitive process, it's very simple, clean process of transferring the needle, placing a stitch, reloading, and working your way down the line. Pretty soon we're going to drop this suture, and we're going to cinch it down. That's what you're seeing right here. So here the majority of that opening has been closed. And then we'll finish up at the bottom here with the last little bit that's left. The title of my presentation dealt with stenting for closure. So I'm going to make just a few comments on stenting, not going to elaborate much. It's definitely a critical step for any uncertain closure by any method that's being used. So I've just went through what I think are confident closures. If there is no confidence at the end of the closure and there is a lumen that will allow it, stenting is invaluable. And here we're talking about fully covered stents. These are the stents of choice for ensuring that a closure will be effective and there will be no leak or contamination. And now today we can get rid of the stigma of using fully covered stents in benign scenarios where there's no luminal stenosis by suturing them in place and preventing them from migrate. So in 2014 there's really no excuse for a migrated stent, because once they're placed one can anchor them with sutures. Now we're going to shift into endoscopic full thickness resection. This is a whole brave new world for interventional endoscopy. I think it's extremely exciting, and it's, I think, a logical progression, along with Stavros, he thinks similarly, in interventional endoscopy. And it's an obvious need for secure closure. The foregut, I think, is a little more favorable environment for direct closure. If you remove a set within the stomach is nicely housed around by the liver. There's omentum right below the greater curvature. Most people have a nice big fat pad in the proximal stomach. So when you make a full thickness closure, there's not a lot of haste that's needed to close that, because it kind of self-seals itself more or less. In the hindgut, especially the rectosigmoid, it's a less favorable environment. You could either be within the mesentery, in which case there's a little more time on your hand to close up the opening. Otherwise, you're in the free peritoneum, and that's where a lot of people have taken a look around, seen the liver and the spleen. And so it's a little less favorable environment, needs definitely a secure closure. We're working on this in our developmental animal lab. This is one closure technique that depends upon tunneling to effect a closure before the full thickness resection is made. So it's closed before cut. So this is the process of identifying or marginating the target area to be removed. Tunnel is made on either side of the target area, and then the tunnels are connected with a mucosal incision. We then lay in a suture and surround the target site. The suture is cinched, and in the process of cinching that, it draws all the walls of the organ together, and so you have serosal to serosal apposition, at which point we have some sutures placed in the target area, comes out the mouth or out the anus, and we can pull on it, tent it up, and make sure that this closure is snug, and at which point we cut off the target area, and you can close that as well with suturing, although it's probably an optional step. This is it in reality. There's the target area to be removed. This is the tunneling process. Here's a tunnel on one side of the target area. These are the tunnels. And now the tunnels have been joined. And this is what you get with the isolated. This is all normal tissue. This is bad tissue. And these are sutures, in this case, coming out the mouth. We can just literally slice that off, and everything's protected because it's closed underneath. Another option is to cut out the lesion, which is the most natural thing to do, and then close it. It can be done a variety of ways. We're currently working using this a type of a foam plug. It's a foam that's biointegrative, meaning it allows cells to grow into it, and it's also biodegradable, and it'll also degrade over a point in time and allow the closure to complete itself. Probably could be done with meshes as well. And as I mentioned, the most natural plug that can close things confidently is the Omentum. And this is a larger version of, this is a stomach that's been perforated several centimeters. It's one of these plugs inside. The stomach's encased in a plastic bag to maintain the gas, and we can see that just the plug alone works pretty nicely in allowing a seal to develop. This is the method by which the plug is used. So this is a several centimeter full thickness opening in the stomach. Plug is placed. This will also show you how the full thickness resection was made. You can watch that as a sidebar. But the plug is first anchored to the mucosa on either side. It keeps the plug from falling through the hole, which we don't want. Then we have to go fishing around looking for it and contaminate a lot of stuff. And the goal here really is to just take the mucosa and sew it over the plug. The plug is really doing all the work in this setting. In the example I showed you earlier, it's a very technical procedure to make a safe pre-closure before you cut off the lesion. Here we're relying on the plug to take care of the defect and take care of removing any spillage and soiling. Once the plug is sutured into place, then we just take the mucosa, we call it suturing, so it's kind of a Z-looking pattern, and take the mucosa and overlay the plug with the surrounding mucosa. And it just kind of puts an umbrella over the plug, and it allows the plug to allow the perforation or the viscerotomy to heal over time. And as I mentioned, the plug itself is made up of a foam material that's biointegrative and biodegradative at the same time. The top part of the plug, which is on the lumen side, is impermeable, so it should overlap the hole and prevent things from seeping through while the rest of the plug does its bio thing. So here you can see it slowly closing down with a series of sutures over it. So where are we in the world of suturing insofar as reports, publications? And just in 2014, there have been 30 abstracts and videos submitted to DDW and SAGES. 3 orals will be in DDW this year, 2 for SAGES. There are 5 manuscripts that have been accepted, 8 awaiting decision, and 12 in preparation. So suturing is definitely growing in attention and interest. If we look, if we graph publications in suturing, you can see this peak right here. This is the era of notes. And then once notes have waned a little bit, they kind of dropped off. And now that clinical suturing is back on the scene, we see a burst in reports in suturing. These are styles of closure that have been published. So we have multitasking platforms. These would be robotic-type platforms, through-the-scope devices, including over-the-scope clips, and suturing devices in the darkest. And as you can see, again, in the notes era, a lot of attention to suturing, and then it drops off. And now that we have a commercially, clinically available suturing tool, it starts to pick up again. So what is being sutured other than full thickness openings in the GI tract? Well, probably the number one application of suturing right now is revision of the Roux-Y gastric bypass gastrojejunostomy. This is the number one application. It's followed next by stent fixation, which I showed you. It's followed then probably by sleeve gastroplasty for weight loss, which you'll see today. And then fistula closures, full thickness defect closures, refractory GI bleeding, and even the GERD scene is starting to pick up with suturing once again. So these are the wide range of applications that can be accomplished with flexible suturing. So in conclusion, as surgery has evolved from open access, open incision, to laparoscopic to endoscopic, suturing is the primary metric of complexity and ability. Endoscopic suturing may be, in fact, the facilitating modality of future, less invasive interventions. And endoscopic suturing, as well as other closure methods, I think successfully address current clinical management problems in addition to the closure which we talked about in intestinal lumen defects. And I thank you very much at this early hour of the morning for listening to what I have had to say. Thank you.